So welcome everyone and good evening. I want to welcome you to the April ASJ Journal Club presented this month by the Young Aesthetic Plastic Surgeons Committee. Tonight we're going to be discussing the article entitled "The Value of Averageness in Aesthetic Rhinoplasty. Humans Like Average Noses." So some reminders, please mute your microphone at this time. We'd like to make tonight as interactive as possible, so please ask questions in the chat box or raise your hand. And we'd love it if you would turn on your video when you make comments or ask questions. So tonight I'm joined by YAPS committee member, Dr. Deniz Sarhaddi, who will be fielding questions and presenting poll questions, and we'll review the poll questions at the end. So I'd like to begin tonight by introducing the author and the discussants, and then we'll get into our discussion. So tonight we have the privilege of having author Dr. Floris van Zijl. He's coming to us live from the Netherlands, where it's currently 2 a.m. So Dr. van Zijl, thank you so much for joining us. So he completed training in otolaryngology at the Erasmus Medical Center in Rotterdam, the Netherlands. After residency, he completed a fellowship in facial, plastic, and reconstructive surgery, also in the Netherlands. He's currently a consultant at the Erasmus Medical Center, and he's about to complete a PhD that focuses on outcome measurement in rhinoplasty. So thank you so much, Dr. van Zijl. So both of our discussants are masters of primary and revision rhinoplasty and really need no introduction. First, Dr. Toriuimi, he attended Rush Medical College in Chicago and completed a 5-year residency in otolaryngology at Northwestern. He also completed 2 fellowship training programs in facial plastic surgery. After spending 30 years at the University of Illinois at Chicago, Dr. Toriuimi recently transitioned into private practice and is a clinical professor at Rush University. He's a past secretary and president of the American Academy of Facial, Plastic, and Reconstructive Surgery and serves on the editorial board for Plastic and Reconstructive Surgery, the Aesthetic Surgery Journal, and Facial Plastic Surgery and Aesthetic Medicine journals. Dr. Toriuimi has published a 3-volume, single-author textbook entitled Structural Rhinoplasty: Lessons Learned in 30 Years. The book is accompanied by a mobile app that has many features that will enhance rhinoplasty teaching. Thank you so much, Dr. Toriuimi, for being with us tonight.
Pleasure.
And finally, Dr. Mark Constantian. Dr. Constantian is a graduate of Columbia College, Dartmouth Medical School, and the University of Virginia School of Medicine. He's been in private practice in New Hampshire since 1978. He's a clinical professor of surgery at the University of Wisconsin School of Medicine and a visiting professor of plastic surgery at the University of Virginia. He's the author of more than 100 textbook chapters and peer-reviewed papers. Since 1977, he's received 23 regional, national, and international awards, including the Lifetime Achievement Award from the Rhinoplasty Society, the Goldwyn Award, 7 Founders Awards from the New England Society, Clinician of the Year from the American Association of Plastic Surgeons, and the Tiffany Award 3 times from the Aesthetic Society. Dr. Constantian also received the Key to the City of Nashua in 2015. His second textbook, Rhinoplasty: Craft and Magic, was published in 2009, and his most recent text, Childhood Abuse, Body Shame, and Addictive Plastic Surgery: The Face of Trauma, was published in 2019. Thank you so much, Dr. Constantian, for joining us tonight.
Pleasure, Mark.
So at this time, let's get started. We will turn it over to Dr. van Zijl, who will share his screen and begin telling us about his article.
Yeah, Frieder, can you enable me to share my screen?
I thought I had done that, but let me just take another quick look.
Yep.
Give me a moment. Let's see. Oops. Okay. You should be good to go.
Yes. All right, so apparently my connection is not very stable. If somewhere through the talk you can't hear me anymore, please let me know. Please interrupt. Okay, thank you very much for the introduction. Thank you very much for the invitation as well. I'm delighted to be a part of this journal club. Looking forward to the discussion. The paper is entitled The Value of Averageness in Aesthetic Rhinoplasty, Humans Like Average Noses. This paper investigates the role of averageness in the perception of nasal attractiveness and is the result of a collaboration between our department in Rotterdam and Professor David Barrett's psychology lab at the St. Andrews University in Scotland. I have no disclosures to report. Right, so as a rhinoplasty surgeon, it is imperative to have a thorough understanding of facial aesthetics and an understanding of what constitutes an attractive or ideal nose. An idea of an attractive face dates back all the way to the Egyptians. They were the first with a real conception of beauty. And over centuries, this has evolved into a neoclassical canon that was designed by artists like Dürer and Da Vinci, and that we still see in our textbooks today. However, the validity of these canons has been questioned. Numerous studies, especially the anthropometrical studies from plastic surgeon Leslie Vargas, show that only a minor percentage of the population actually exhibits the ideal neoclassical canon. Yeah, there is a question about the validity of that. Furthermore, the majority of attractive faces do not conform to these canons any more than do less attractive faces, also shown by research. But apart from us doctors trying to find out what is attractive, evolutionary psychologists have also extensively studied facial attractiveness from a different point of view. And their research has identified cues or traits of what humans find universally attractive in others. And examples of this are symmetry, but also youthfulness, sexual dimorphism, which basically means that a male with more masculine features or a female with more feminine features is more attractive. And another cue is averageness, and various psychology studies have proven that especially averageness, mathematical averageness, is a very robust feature of attractiveness. Right, so our goal was to study the relationship between averageness and attractiveness for the nose. To do this, we recruited 80 Caucasian female volunteers aged between 25 and 40, as that group encompasses the majority of aesthetic rhinoplasty candidates. And we took standardized photos of the face. And on each photograph, standard landmarks were positioned to delineate the facial features. And then the average position of each corresponding landmark across the set of faces was used to create a composite blend. Here you see a selection of the original photos, and on the left, the result of blending all these faces together mathematically. We then organized a panel of raters from the general public and asked them to score each nose of the original photos and the nose of the averaged composite, which were presented in random order, and also both as a whole face and as a nose in isolation. We used a 5-point Likert scale, ranging from 1 being very ugly to 5 being very attractive. And we then averaged all raters' scores for each image. And we found that the composite nose was rated significantly higher than the mean of the original images. And this was the case for both the full face as well as the isolated nose images. However, looking closely at the average composite again, as you can see here, might suggest that there are perhaps confounders that also dictate the degree of attractiveness. It looks quite symmetrical, first of all. And second, averaging images also introduces a smooth skin tone because you level out all skin blemishes. So perhaps symmetry or skin tone were responsible for the increase attractiveness and not average nasal shape. So to test whether average shape itself is truly responsible for attractiveness, we performed a second experiment. And in this experiment, we investigated whether a correlation existed between nasal shape in profile view, thus eliminating symmetry, and the attractiveness rating. And we first calculated how much each original nose deviated in terms of shape from the average. We did that by using the variance of X and Y coordinates of all landmarks between the images. And we were able to narrow that down to a single metric using a principal component analysis. And we then looked at the relation between this shape deviation score and the attractiveness rating. And we found that the more a nose deviates away from average shape, and the less attractive it is rated. Or put the other way, the more a nose resembles average shape, the more attractive it is, irrespective of symmetry or skin tone. So finally, what does this tell us and what can we do with it? Well, first of all, it improves our understanding of nasal attractiveness. But secondly, there may be a potential to use this concept in practice. The left image of these participants is the original image. And in the second image, the programmed software has automatically repositioned the nasal landmarks into average shape. What is interesting to see is that these noses have indeed become much more pleasing compared to the original. And in fact, if you set average nasal shape as a surgical goal, you could hypothetically let the software calculate deviation from average pre-operatively and again post-operatively. And then you would get an objective idea of how good the outcome of the rhinoplasty has been. Of course, further research will be necessary to substantiate that. Yeah, that's why we think this is something promising. Thank you for your attention, and I'd like to give the word back to you, Mark.
Thank you, Dr. van Zijl. Excellent presentation. So at this time, we'll have Dr. Toriuimi say a few words, if you don't mind. Thank you.
First of all, I'd like to thank you for inviting me, Mark, and it's a pleasure being here working with my good buddy, Mark Constantian. Floris is an excellent paper. It's should be commended on the depth of the study, the quality of the research, and the design. It was very well done, and I commend you on the effort. And it does provide, I believe, very important information for us, because as surgeons that do facial aesthetic surgery, we're always striving to meet standards that are higher and higher as we improve our technical skills and our surgical techniques. What I found very intriguing about the paper is that when you look at probably the most important aspect of the nose, particularly on frontal view, you see characteristics that I agree to that they would be considered ideal in all aspects. When you look at that slide that Floris has right there, and if you look at the middle view on the bottom row, you see symmetric brow tip aesthetic lines, dorsal aesthetic lines that are coming down. They're relatively uniform. But what's important to note is as you reach the bottom of the nose, there's a slight flare, outward flare at the base of the nose. And so this is something that's really important, and it basically emulates a natural appearance to the tip. The tip is not pinched. In fact, the width of the tip at the base of the nose slightly flares, and that's a characteristic that all of the present day rhinoplasty techniques that are considered popular right now try to emulate that. And that means we want good support from the tip lobule out to the alar lobule. So what are people doing to try to achieve those things? One thing that a lot of people are doing is they're using dome sutures with articulated rim grafts or just conventional rim grafts. What do those grafts do? They create this triangularity of the base and the smooth transition from tip lobule to alar lobule. So the frontal view is right on. I agree with 100%, and that really aligns with a lot of the aesthetics that we see. I published a paper in '96 where we looked at models from different magazines, and we came up with a composite of the tip, and it looks very similar to this shape. When I look at the lateral view, it's a little different from what I would consider ideal, but I think this is regional, because I think if you look at noses from Germany, in that part of the country, they're going to be more projecting, they're going to have a slightly higher radix, they're going to have a higher dorsum, they're going to tend to have a convexity, and those are just characteristics of that part of the world. Whereas if you go to Asia, you're going to see something completely different. You're going to see a lower dorsum, lower radix. The tip is going to probably be leading the dorsum. And then if you go to the coasts in the US, let's say you go to Beverly Hills and then you jaunt over to New York, you're going to see different aesthetics. They're going to be significantly different from what you're seeing in that image, because there's really no super tip break. There's a slight convexity. And then so it's significantly different from what many surgeons on the coast would try to achieve. So does that make it wrong or incorrect or not accurate? No, not at all. Again, when we do surgery as rhinoplasty surgeons and we change the shape of people's noses, you have to be able to adapt to the patient's requests. When we do computer imaging on these patients, it's amazing to me how many patients want the slightest little convexity left on their nose, or maybe they don't want a super tip break. Whereas you have another group of patients that maybe come from the West Coast that want a more pronounced super tip break. So this is why these type of studies are important, because what it does is give us more information. And as knowledgeable surgeons who have really good techniques, and we can create any shape to the nose we want, you have to have a goal. And the goal in mind is based on your aesthetics, the aesthetics of the patient, and how you come to agreement. And the information that Floris provides in this paper gives us even more information that we can use to educate our patients on what is a good outcome, particularly on the frontal view, what are the proper normal natural contours. And so again, Floris, I congratulate you on a high quality research project, which is providing us with excellent information that we can bring to surgeons, but even more importantly to the patients. So I'll go ahead and pass the baton on to Mark.
Thank you so much, Dr. Toriuimi. And Dr. Constantian.
I'm glad to have heard the presentation from the author, and I'm glad to have heard Dr. Toriumi's remarks. For years, we've said that we need more scientific papers in aesthetic surgery. And when I started in the Aesthetic Society, there weren't any papers like this. So I think this is terrific. And I kept thinking, as I thought about this, I kept thinking there was something that bothered me. And my job as the discussant is not just to praise you, but to provoke you a little bit and let you defend what you're saying here. I understand the variants, and I see that the reference to Bashur's paper in one of your references, where he showed how many of the neoclassical canons didn't apply in real life. Like my favorite one is that the interalar distance should be equal to the intercanthal distance. That was only true in 30% of Caucasians, and never in blacks, and never in just a small percent of the Han Chinese. So if people try to make those fulfill those criteria, they're going to end up with the results that don't look good. I think averageness makes a lot of sense when you're talking about the skeleton. So for craniofacial surgery, I think it makes sense. For ulnar variants, it makes sense. The minute you add soft tissue, I think it messes things up. So for example, we have aesthetics for breast contour, ideal breast. You can't achieve that in everybody. There are aesthetics, I suppose, for body contour, but what you're going to get, how well you can fill those aesthetic goals in body contour in a woman who needs liposuction and in a person who's undergone post-bariatric surgery is totally different. You can't achieve the same in either one. And so, and in facelift, same thing. The minute we have standards for the neck and the jawline and the cheeks, but there you're controlling the skin volume. In rhinoplasty, you aren't controlling the skin volume. That's the difference. You've got a skin sleeve that is not a passive tablecloth. So even if you make a perfect skeleton, the nose isn't going to take that shape on if the skin can't react to what you've done to the skeleton. The other aspect of rhinoplasty is that there's a strong, and Dr. Toriuimi mentioned this, a strong ethnic, familial, and personal element to nasal aesthetics. So people don't come in for a facelift and say, I want to get back my Armenian jawline. And I wouldn't know what that meant. But if they come back and they say, I've lost my ethnic identity because of nasal surgery, or I want a rhinoplasty, but I want to keep some bridge height, like Tori meant, or I don't want too much shortening, or I don't want too angular a tip, or I don't want a super tip break. Those are very individual things. So what you're really talking about here is how you set a goal with the patient. And I think that's probably the most valuable part, discussion for the whole group. When I look at this picture, I agree with Dr. Toriuimi about the aesthetics, particularly on the front view. The lateral view has a super tip convexity that I don't care for, and that I think a lot of patients wouldn't care for. So I'd like to hear Dr. Van Zijl's own take on the aesthetics here. The other thing is, this person, these ideals, how would you achieve them in someone with a broad nasal base, someone with a big hump and a long nose? These can be a general guide in your own mind, but at some point you have to bring in what the patient has said is his or her goal, and you have to look at what's actually achievable given the soft tissues you have and the bony structure you have. I'm not sure Dean exactly meant we can make any nasal shape we want. I can't do that. I'm struck with the limitations the patient brings me, and that's a lot of my preoperative discussion. You've got a large nasal base. You've got skin that won't contract. So I can give you a straight profile. I can give you tip projection. I can give you a good airway and better symmetry, but I can't give you a straight nose in several different sizes because you have a certain skin volume, like you have a certain height or eye color. So I'd like to know, one, what you think of the image you just showed, the composite image. What do you think of the aesthetics? If someone came in and said that a guy in town that maybe you don't even like that much had produced this rhinoplasty result and she wasn't happy, would you say that's a good aesthetic, you don't need more surgery, or would you want to make a change? And then secondly, how do you set a goal with the patient? Because to me, the averageness counts in social psychology. It may count in craniofacial surgery, but for me, averageness is not part of the surgical discussion.
Yeah, thank you very much for your comments. No, I definitely agree with you here. It's for the majority of patients, it will be impossible to create exactly this average nose, definitely. You will not have the tissue, it will be too difficult. Definitely it includes the skin as well, which you indeed are not able to manipulate. So saying that an average nose should be a goal of every rhinoplasty is definitely not the case. I agree with you there. However, I do think that it can guide as a template that you can work towards and see how close you can get to that, as long as the patient is happy with that as well. A small remark about the differences in ethnicity, also a very valid point. I have to stress that this is only an average for Caucasian females between 25 and 40. So definitely we have to repeat this for other ethnic groups to see what their average shape will look like. Yeah, regarding whether I see this as ideal, I think that what I've been learned is that a good nose is an inconspicuous nose. A nose that shouldn't draw attention, but instead let the more pleasant features of the face draw attention, such as the eyes and the mouth. And in that respect, I think that averaging a nose with an average shape equals an inconspicuous nose. And in that respect, I think it can be a good result of rhinoplasty. But of course, there are different styles. Patients may have different demands as well. So it's definitely not a one size fits all.
So how have these research findings affected your practice? How do you discuss with patients and set a goal? Does averageness trump personal aesthetics? Do you try to bring them toward an understanding of what the average is so that they like it better? How does this work in practice for you?
The majority of my patients are insured patients who undergo functional or functional aesthetic rhinoplasty. But what I do is I show average size or average shape and discuss with them what they think about it. But I also have to admit that most revision cases, it's useless to show them these pictures because you'll never get there. I use it most frequently in my own preoperative planning, especially for primary cases. I use this template to see what changes someone needs and really put those next to each other. I use it for my own idea of where a nose should go to.
So if I may, we have the privilege of having two masters with decades of experience. Can I turn the question around to you? What have you learned through the years that works as far as setting goals, and what is that conversation like with patients? What works, what doesn't work? I know Dr. Toriuimi mentioned computer imaging. If you could both comment, I'd appreciate it.
I'll go first, Mark. So I did mention in my earlier comments that computer imaging is critical, but Floris, I wouldn't underestimate your capability. I mean, I believe that Mark, all of us on this call, we can achieve those frontal view appearances. We can achieve those lateral view appearances. They're very, I mean, if you want to call it average, you can call it that, but those are achievable. Now, would I make the lateral view the same as those images? No, I probably have it a little bit lower, maybe a little bit of a super tip break, but the frontal view is right on. And again, using the techniques that we use today, we can achieve those contours, particularly now at dorsal preservation. Those upper third, middle third contours can be readily achieved. So how do we communicate this with our patients? I think a lot of it, the patients come in and they're already knowledgeable. It's a little scary sometimes on how knowledgeable they are. They'll call the nose upper 2/3, they'll call it dorsal aesthetic lines. They'll say, well, I want my tip to look like this, and they show pictures of models or celebrities, and almost universally, those people have a natural looking tip. And that makes my job easier, because then I know that I don't have to push the margin to some extent with respect to how narrow I make the tip. I just need to make the tip look normal, natural, less fullness in the superalar area, a nice triangular shape at the base where you get that nice flare with a good support from the tip lobule to alar lobule. And we can achieve all these very confidently with our present day techniques. And that's where I see this, Floris's work on the aesthetics, particularly on the frontal view, and the work that other surgeons are doing in developing all of these new techniques. And they all have the same underlying structural concepts that are creating very similar looks to the tip. It's not the same as the tips we were creating or people were creating in the 70s. It's different. It's a different look. It's a natural look. It looks just like your frontal view image, Floris, that you showed as the average. So I think things are converging here. We're seeing a converging of what the people want, what our patients want, what the science shows, and what we can create surgically. That's the best of all different disciplines, and that to me is very encouraging.
Dr. Constantian, I know that I think that you don't use computer imaging. Do you mind walking us through the conversation you have with patients to establish goals?
My guiding principle is always that the patient determines the normal. The patient sets the aesthetic. I really don't listen to anything else. I would never go into a patient and say, you've got a boxy tip, you've got a ball tip, you got whatever. I assume they want a good airway. So I'm looking at the middle vault, I'm looking at the position of the alar cartilages, that's the frontal view. I assume they want a straight profile, maybe with a little convexity. They want adequate tip projection. But within those bounds, I let the patient tell me everything. So I start with the frontal view. How do you feel about the nose from the front? Well, it's too wide up here. It's too wide at the bottom. If they don't mention, or it's crooked. If they don't mention the tip, and some patients don't, I'll say, what do you think about your tip? Oh, it's all right. That means I'm going to do much less to that tip. I might trim the cephalic margin. I might add a little tip graft for contour with the patient's permission. But there are also patients who come in with the same tip, and for them, this is the #1 priority. They hate the tip. It's like, if I can't get the tip dramatically better, the whole operation's a waste of time. So there, I'm going to be more aggressive in what I do. I'm going to move the malpositioned lateral crura. I'm going to go through a longer explanation of the problems we might encounter. And on the profile, I'm listening for things like, I don't like the bump, but particularly when they say, my nose sticks out too far. To me, that's a proportion problem. So then I'm starting to look for the low radix, places I can not reduce so much, try to get better proportion. And I do, when patients come from ethnic groups where there's an identifiable appearance, particularly a dorsal convexity, and particularly in men, I will ask them if they would like to keep some of that height. Armenians, Greeks, Jewish people, Middle Eastern, some Italians, they will be very emphatic if you give them the alternative of preserving some of that dorsal height, because for them, it's the way they've always looked. And that's one of the commonest problems I see in secondary patients, particularly men. Even if they come in with a straight dorsum, they feel somehow the first surgeon feminized their noses. So I used to have patients bring in photographs. Some still do. And I never felt it got me in trouble. It gave me an idea of how much dorsal height they wanted, how angular a tip they wanted, how short the nose could be. And then I try to take this photograph and make it fit what I think I can actually do. So if a patient comes in and they've got a much smaller, shorter nose than I think is possible, much narrower, I'll say, this person is a different ethnicity. She's got different skin. She's got different bone structure than you do. But I can give you a straight profile like she has. I can give you better proportion because your radix begins low and hers begins much higher. And if we fix that, the lower nose won't look so large. I can make your tip look prettier so you've got a better profile. But like I said earlier, I can't make a straight, patients can't have a straight profile in several different sizes. I think the idea that we make smaller noses for smaller people and so on, that's surgical bravado. We don't have that much leeway. So I try to hit the meta goals with the patient, give and make their ideas meet something I can do. And if I can't, then I'm not the right surgeon for them. And I don't do computer imaging. I have at this point books and books of pre and post-operative results. So I can match most kinds of problems patients bring me. And as I show them these, preserved dorsal height, more retroussé, less retroussé, change in length, I'm watching their reaction to them. If they don't like the change, That worries me. If they don't see the difference, occasionally patients say, which is the before and which is the after. That's really a bad sign. But if they will make, some patients will be very fussy about how much projection beyond the super tip they want. And I had this conversation with a woman yesterday. She doesn't want any. And I said, okay, I'll do my best, but you've got to understand your world as a basic scientist is different than my world. I can set what I want, but once I put the dressing on, it's in nature's hands. And I think I can do this, but you've got to give me some leeway, or else I shouldn't take you as a patient. I'm trying to bring realism into it. So for me, it's area by area analysis and a lot of discussion about personal, familial, ethnic identity.
I'm curious with all the speakers, I'm sure you've all had this patient come in who otherwise is behaving pretty normally, but they are pretty obsessive about their pre-op appearance, as far as this nostril being 1 millimeter higher than this nostril, and this, half a millimeter higher on the left than the right, just enough that your antenna may go up. But otherwise, their behavior is fairly normal. What do you do about those patients? Do you operate on them? There are certain questions that you ask them before you decide to operate on them?
Yeah, well, Mark, that's probably half my patients, so it makes life a little tricky. But no, see, the problem is now that everyone's taking selfies and they're looking at their pictures all the time on a screen because they're doing, virtual meetings. It's even more important for us to work on these little asymmetries and the nostril symmetry, and work really hard on the frontal view. Mark mentioned that he doesn't do computer imaging, but he shows photographs and he gets the body language. I image right in front of the patient and their family. So I am moving the dorsum, shaping the tip live in front of the patient. And why do I do that? Because the same thing that Mark talked about. I do something, I kind of turn back, I do something, and the patient's in my vision. So I can see how they're reacting as I'm doing the imaging. 95% of the time, they like what I'm doing. But occasionally you'll get a patient that you can see they're crossing their legs, they're not comfortable, they're going, they make a little noise. And then, so that's where there's a divergence between my aesthetics and their aesthetics. Does that mean that they're not a candidate? No, but that means that I may need to adjust somewhat my aesthetics to meet theirs. That's where the difficulty in the decision-making becomes more complex. When your aesthetics are in alignment, then as long as you reach that goal, you're going to have a happy patient. It's when you have slight divergence in your aesthetics, because then you have to alter your goal. And maybe you're doing a surgery and your right side of your brain's telling you to go here, but the imaging is telling you to go in a different direction. That's where you have a conflict. And that's where I sometimes have difficulty, because I do get patients who come in and they say, I want a dorsal hump. I want no super tip break. A lot of the Asian patients want a wider bridge, wider nose, no super tip break. So the aesthetics, as Mark said, varies tremendously different throughout different ethnic groups. So we have to be acutely aware of that. What we can't do as surgeons is say, well, the patient really doesn't understand, so I'm going to give them this shape despite what they want. That's what we can't do. That's not what we should be doing. If you don't want to take on or try to achieve the shape that they want, then you should refuse them as a patient and explain to them, our aesthetics don't align, I really don't feel comfortable doing your surgery. That's a good way to dissociate in those situations.
I think a lot of it, of the working with the patient you're describing, Mark, is education. I will point out asymmetries that I see. People who have prominent foot plates, or the caudal septum is in the one nostril, and they may not even understand why the nostrils are different shapes. But they have to understand, people have to understand that a certain amount of asymmetry is unfixable. And it's within the variation of what's normal. And if people point out a problem to me, my idea is, okay, one nostril's higher. Is it high enough that I can bring it down with a composite graft? Can I fix this with a high likelihood of effectiveness? If I can't, and the patient is adamant, then I'm going to back away. There are some patients I can educate out of some of the things they come in thinking they need to have fixed. And so I need to first be able to see the problem the way the patient sees it. If they're pointing to something I don't see, or they're using words like disgusting or huge, or I mean, catastrophic language to describe problems that are minimal, that's a big problem. One woman said to me, when they took off the dressing, I looked like an animal. I didn't operate on her. That's really troublesome. So language is very important. So I have to be able to see it the same way the patient sees it. And I have to personally be able to feel I can fix it. Now, I can fix more things now than I could fix 20 years ago. So I have a man that I'm going to operate on in a few weeks who's a former patient of mine who has a little tip asymmetry. And he's one of the most obsessive people I've ever met, but he's not obnoxious. He's just a worrier. He creates problems for himself all the time. And I can subtract a little from one side and add a little from another. I think I can fix the problem and put his mind at ease. Now, 25 years ago, I probably would have turned him away because he's so intense, but I think I can manage him. I have to feel a patient understands, is manageable, meaning can I put the dressings on? Can I do the packing? If there's bleeding, can I deal with them? I have to feel that patients will understand if there's a complication that I'll be able to work with them. And finally, patients have to understand that the goal I'm shooting for is the best possible surgical outcome, not perfection. I think people come to us as specialists, as plastic surgeons or facial plastic surgeons, or as rhinoplasty experts, thinking that our success rate is perfect. And I will go through complications, and for everything I'm going to do, I explain the chance in percentages that I think I might need to do a revision if the patient wants the best possible result I can provide. And I'm watching how they react to that. So all that is feedback for me. But little asymmetries in a patient who can't be educated and won't give up the obsession is a problem. I wouldn't do that.
You know, just to follow up on Mark, so we talked about imaging and its utility and how we educate patients. One important point is when you do the computer imaging, you don't want to create a perfect image. And I typically will intentionally leave imperfections. And the patient will tell me, well, Dr. Toriuimi, look, that nostril's not quite right, and that tip there over there, it looks a little funny. And then I'll respond to them and I'll tell them, my intention is to do the best I can for you, but I've never had a perfect nose in 32 years of practice. And, you know, they look at me funny, like, oh my gosh. But we don't want to set expectations that are beyond our capability. That's really important. Mark brought that up a couple times. And it's probably a good way for us to educate patients on what the outcome what they can expect as an outcome. Expectations are so important when you work with patients, particularly the secondaries, because the secondaries may have had 3-4 prior surgeries. They're traveling. When people travel, their expectations are higher. I think that's just universally across the board. And so when we deal with these patients, the ones that are really particular, we have to put them in a psychological state where they understand they're going to be swollen initially. It's going to take years for that their shape to finalize. And most importantly, perfection is very difficult to achieve, if not unachievable.
I think for me, to follow up on what Dean just said, it's not just my surgical skill, that what I can do, it's what nature will let me do. So in the 2 simulations that you had, Dr. van Zijl, I'm not sure I could get those results. The first one on the left was a short nose. You got nice length, but if that skin sleeve is tight, it's not going to come down that much for me. And the other one was the same profile with the base set back, but I'm not sure that's possible either, because you can reduce the skeleton, but that skin won't come in that much. You're just going to end up with a super tip deformity. So for the surgeons listening, if you're doing imaging, just like Dr. Toriuimi said, you have to image something you can actually do, that nature will let you do, not something you'd like to do, because you're dealing with a skin sleeve and skin distribution that's more or less fixed in thickness and in volume.
These are excellent, excellent comments. Thank you so much. So we have Dr. Sarwar, who wrote a great commentary to the article. He's in the audience. Dr. Nahai is in the audience. We'd love to hear from as many of you as possible. Feel free to raise your hand, ask a question in the chat box. In the meantime, we'll turn it over to Deniz Sarhaddi, who can please review some poll questions.
Sure. So very much along the line of this conversation, we polled the audience to see how many of our participants today have a preset template in their mind, kind of a goal in their mind, either for Caucasian, for Asian or African-American rhinoplasties. And the majority of the group actually has no preset template in rhinoplasty for these patients. Similarly, 67% of our participants do not follow the rule of vertical fifths. I think the article was interesting in that it showed that the average, ideal, most attractive nose was a little bit wider than the interalar intercanthal distance. So along that vein, 67% of our patients don't follow that rule. And similarly, 73% of our patients do not set out to create an average nose. So, you know, I think a lot of what Dr. Constantian was saying in terms of doing what you can for that patient fits in with that. And I think that knowing your goal before you start doesn't necessarily mean know your template. It just means know what you can do for the patient.
Deniz, I have my hand up. May I ask a question?
Yes, Dr. Nahai.
First, I would like to thank Floris and welcome him to ASJ Journal Club. It's well past 2:30 a.m. in Europe. Thank you so much. This means a lot to us, and we're proud of the fact that your national society is affiliated with ASJ. My thanks to both Dean and Mark. I have a question for you, and I think we've been talking about managing expectations, and I'd also invite Dr. Sarwar to comment. Would you both comment about any concerns or differences when you're dealing with a male as opposed to a female in terms of managing expectations? And then, of course, if we have time, even the ethnic differences. I think, Mark, you reflected on some of my own ethnic background, and I find that in my practice, be it facial aesthetic surgery and especially rhinoplasty, where I have the toughest time is managing expectations of those with my ethnic Middle Eastern background.
Fouad, it's good to have you, good to talk to you and see you. I would, to answer your question, there is a definite difference in aesthetics, obviously, between the female and the male patient. But what I do notice is that the aesthetics in some situations are getting a little closer to each other. I think, 15 years ago, I think male patients were a little more acceptable to having a dorsal convexity left and maybe a more projected, wider nose. And I think at least the patient population I'm seeing in the males, it's shifting a little bit more to more of a super tip break, maybe a little bit lower of a dorsum. Now, this doesn't include the ethnic patients. I'm talking about purely patients, Caucasian, maybe primarily from the US, and not including Asian and Black patients. So when we look at this group, the male patients, I think, are moving a little bit more towards, I wouldn't call a feminine nose, but I would call a smaller nose, less projected with less dorsal height and narrower as well. On the other hand, the females, I see them with fairly consistent but natural aesthetics, similar to what Floris showed in his paper with the average image. And then with respect to ethnicity, I do a lot of Asian augmentation rhinoplasty, and it is amazing to me the differences in the aesthetics between the Asian patient and the Caucasian patient. The Asian Chinese patient, Japanese patient, Korean patient, I mean, we're looking at augmentation rhinoplasty, which is pretty much adding material to these patients as opposed to taking anything away. So it's a completely different operation. And so we do make significant adjustments to allow us to then accommodate the patient's desires.
I think there are some differences, but it's very individual, male, female. I think men in general don't want as much shortening. They want to keep more height to the bridge, but most want adequate projection and good airways. And I think probably part of the reason you're asking is because of the reputation of male patients for being so much trouble. And I think I've changed my mind about that. I presented a paper years ago at the Aesthetic Society. I'd looked at 1,000 consecutive rhinoplasties. This must be 15 years ago. And the number of male patients that created a problem was disproportionately high. But as I've seen more of that and read more of the literature, I think it's more a way, I'd be interested in what David thinks of this idea. It's more of the way people who are unhappy respond to being unhappy. Women, in my experience, and according to the literature, tend to get depressed. They drink, they take antidepressants, they go shopping, they go down. Men tend to get angry. I'm not aware of any woman who's shot a plastic surgeon, but the men do. And so I'm not positive that the men, if you manage them right and you manage their expectations and so on, and bring them to what you can do, I'm not sure for me, they're any more difficult. But I think the angry ones may not be more numerous, but I think they're more memorable. That's the way I look at it now. What do you think, David?
So Mark, thanks for you and others for inviting me into this conversation. For those of you who don't know me, I'm a psychologist who was with the Center for Human Appearance at Penn for about 20 years before I moved on to a new position at Temple University, but still sit on the editorial board of ASJ and was fortunate enough to be a discussant on this paper. Mark, I think you raised a really interesting issue there in terms of how the gender differences that we see in terms of responses to disappointment and frustration, and that men may externalize it more than women. I think we need to be a little cautious about gender stereotypes there, but I also think it makes a great deal of intuitive sense. I also think, my take a lot of this, on this historical echo of that men tend to be more problematic patients, I think is also a little bit of an error in recency. We all, an airplane crashes and we all think that airplanes are far more dangerous than we are. We have a patient with a complication. We think complications happen more frequently than they really do. And I think sometimes what we see is we see a particularly angry or upset male patient, and we have this recency bias that that's how all men are going to react. I guess two things that I would add to this discussion, as we're talking about the gender differences and we're talking about perfectionism, obviously we're getting really close to talking about body dysmorphic disorder. And while that wasn't a thrust of this study, I do think it's useful to remember that the rates of the disorder by gender are actually equivalent. That while many people assume that BDD is going to be like the eating disorders and that we'd be more likely to see it in women than men, the largest studies today actually suggest that the disorder is quite equivalent across the two genders. And then the last thing I would add, I think it's important while we've been focusing on the clinical implications of this work, that I think some of the greatest contributions from the study are what it kind of reminds us about perceptions of physical attractiveness, perceptions of physical appearance more generally. So there are nods obviously to evolutionary theory here. We also know that we have this large body of social psychological research that says what is beautiful is good, that when we see people who are more attractive, who have these more symmetrical, average size facial features, we see them as more attractive. But there's actually a very fascinating study that came out of the Center for Human Appearance, my former group, back in January, that is now beginning to float this idea of what is anomalous is bad, in that they have shown that if you put people in an fMRI machine who have elements of facial disfigurement, that the elements of the brain that light up are associated with a visceral negative reaction. And it's almost as if we are hardwired to think that when we see a facial appearance that's profoundly different from the norm, that it may be actually, touching on something that's hardwired into our brains. And so I think when we consider maybe not more modest forms of aesthetic procedures, but maybe, the patients who come in with a really significant nose, and they begin to say, you know, I feel like the world treats me differently. There's some evidence now from our colleagues in neuropsychology who are suggesting that that's in fact what's happening. And I think that that's a really important reminder for all of us that some of our biases about how we look at other people are not just, you know, colored by our consumption of mass media, but they're also perhaps hardwired in as well.
There are a couple of papers that most people, unless they're older, won't remember, but they're worth looking up in PRS. They were both by Milton Edgerton, who was at the University of Virginia when I was there, and he was a big inspiration to me. I maintained contact with him throughout the years, but he always had a psychiatrist in his department, first when he was at Hopkins and then at UVA. And he wrote two papers, one in 1960, I think, called The Patient with Minimal Deformity, and another one called The Insatiable Cosmetic Surgery Patient. And he describes exactly what we've been talking about. I mean, this is long before BDD was even a term, but he saw it. And this is where plastic surgeons, I think, ought to stay involved in thinking about this problem and shedding what our experience is, which is going to be different than the mental health experts. We can all combine what we know. Those are two good papers to read.
Thank you. Well, if there are not any further questions or comments from anyone, I think it's probably time to wrap it up. So at this time, I'd like to thank Drs. Van Zijl, Dr. Toriuimi, and Dr. Constantian for spending their time tonight teaching all of us. We really, really appreciate it. I thought tonight the discussion was absolutely phenomenal, and I wish we had another hour or two to continue it, so thank you. I also would like to thank ASJ Executive Editor, Phaedra Kress, for all of her work behind the scenes to make tonight such a success. Tune in everyone next month for the ASJ Next Generation Editors Journal Club hosted by Dr. Ryan Austin, and we'll be back in June for the next Young Aesthetic Plastic Surgeons sponsored journal club. Have a great night, everyone, and thank you again. Bye-bye.
Thanks for staying up so late, Floris.
Yes,
Yeah,
thank you.
Thank you very much. It was a pleasure.
Nice to talk to you. Good night.
Nice to talk to you as well. Thank you.